SAGES Stories.
Welcome to today's episode of SAGES Stories, the official podcast of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. Please make sure to hit the like button and subscribe so you can stay up to date with our most recent episode and enjoy the show. Welcome to the lucky number 13 episode of SAGES Stories, where we shine the light on some of SAGES' most impactful leaders. I am your co-host, Dr. Shirin Tofai, joining you on the West Coast in mostly sunny Los Angeles, California.
And I'm Dr. Kevin L. Hayek, coming to you from colorful Cleveland, Ohio, where we enjoy not just one, but 4 seasons. So we're in the third of those seasons. So it's pretty sweet.
Yeah, sure, Kevin. We'll talk again in about a month and see how colorful things are for you.
Yeah.
Well, for what it's worth, we are sure to have a colorful episode of SAGES Stories today, as we have the pleasure of Dr. Gerry Fried, we call him Gerry, as our guest on the show. Another SAGES luminary, Dr. Fried hails from Montreal, Canada, where he is currently the Associate Dean of Education, Technology, and Innovation, as well as Director of the Steinberg Center for Simulation and Interactive Learning at McGill University. Little known fact, I almost went to McGill for medical school.
That's right. That's right.
Yeah, thank you. He previously served as program director for general surgery and was a vice chair for surgical education at McGill. Indeed, education is clearly a passion of his, and our astute listeners have heard his name announced multiple times as a mentor for several of our prior guests on SAGES Stories. He has served as president of the Canadian Association of General Surgery, the Central Surgical Association, and the James IV Association of Surgery, which was, by the way, named after King James IV of Scotland, who supported the foundation of the Royal College of Surgeons in Edinburgh. Of course, among many other titles, Dr. Fried was a former president of SAGES in 2013 to 2014. So welcome to the podcast, Gerry.
Well, thank you. This is a great idea, and I'm happy to be included as part of it.
Absolutely. Well, it is just a pleasure to have you on the show. And as Sharon mentioned, your name has come up a few times, and it's great to finally let you share your side of the SAGES story. To start, we always like to hear a little about the background of our guests. Where did you grow up, and what were some impactful moments along your journey in medicine and surgery?
Well, I grew up in Montreal, and so I've come back home to practice, and did most of my education at McGill. It was one of the great steals to be able to go to a medical school that was ranked really in one of the top maybe 25 in the world, and pay a tuition of about $700 a year Canadian in order to go there. So I guess I asked myself, why go elsewhere? I had a great education at McGill, and then went on and did my residency in general surgery at McGill. Went on to Ohio State University to do a year of combined endoscopy and gastrointestinal surgery.
Did you say Ohio?
Ohio. I think we heard Ohio there.
It's the Ohio State University.
Oh, yes. You went to the.
Yes, I did. And
we can't go through a single SAGES story without Ohio or Cleveland being mentioned. Where is that?
While in Columbus, it was a wonderful opportunity. I got to work, of course, with Dr. Zollinger, who was still practicing then, and Dr. Ellison, Chris Ellison, and I were in the same year in residency.
Wow,
so
and he's the new president of the American College, right? So that was your
Yeah, so that was a great thing. I got introduced to American college football in all its splendor, and I did 6 months of gastroenterology in that year, which was really impactful in terms of convincing me of the role of endoscopy in the practice of GI surgery.
When was that? What year was that?
That was 1978 and 79.
And it was before Kevin was born.
I was born in 79, so that was a good year.
Yeah.
So
it was great. Yeah.
McGill is an amazing institution. I heard about it because my mentor, who is the reason why I'm in medicine and eventually in surgery, trained at McGill. And I only applied to McGill because of him and was so impressed because it seemed to me that for whatever reason, whether it's a Canadian thing or it's a McGill thing, like the clinical acumen of people going to school there and being trained there is so much superior. You're not just ordering blood tests and CT scans. You actually had what I felt was superior clinical knowledge of like physical exam and history. Did you feel like that was true?
Well, obviously I trained a long time ago. There weren't CT scans, there, they were
Yeah.
just inventing ultrasounds back then. But unfortunately, this is just an audio, but if there was video here, you would see the background that I have is the Sir William Osler Library.
Wow, that's cool.
And I hope those of you that come to Montreal for the SAGES meeting this year will have a chance to come and visit it. It is spectacularly beautiful, and it's got a collection of ancient books that would be hard to match anywhere. But the reason I say that is that Sir William Osler was really the person that championed bedside teaching and rounds as a teaching experience. So it's been very much part of our, of our heritage. And I like to still think that we can make a lot of diagnoses at the bedside. We could confirm them by imaging, and we generally do that. But it's very empowering, and it's wonderful for students to learn how to make decisions at the bedside. And the thing about surgery is that you often have to make difficult decisions within incomplete information because you're time constrained. It may be a trauma or a rapidly evolving patient.
Right.
So being able to have judgment at the bedside, I think, is a real attribute for any surgeon.
That's great.
Now-
We stopped you at 1979, which was a great year. But we want to hear a little. I know as soon as we hear Ohio, it just gets Sharon really excited. So
My favorite
we need to
state.
stop. Yeah. So you finished 78, 79 in Columbus.
Then I went back to McGill as chief resident. So one of the great things that we had back then, and it would be something really good to emulate now, is that we would select one of our fourth-year residents and send them away for a year of clinical training in a department that had either a clinical practice or expertise that we didn't have. And then they would come back and be a chief resident, be able to bring that knowledge and skill back and share it with the rest of the people.
Yeah.
So I was very interested back then in endoscopy, as I said, and at McGill in those days, surgeons were not allowed to do endoscopy. There was nobody, not even no colorectal surgeons, nobody doing endoscopy. So the opportunity to do endoscopy, to learn endoscopy, was really exciting for me, and that's why I went away. I came back. I did my chief year, and I remember we came back. My wife was about 6 months pregnant with our daughter Kimberly, and I remember her lying there. It was like a really hot July day. We couldn't afford air conditioning, and she's lying in bed with this wonderful body image. And I said to her, "Karen, what do you think about going to Galveston?" Well,
Texas.
She hit me with a frying pan, I think. But sure enough, finished my chief year. We got in our car and we drove down to Texas. And we spent a couple of years in Galveston by the sea, learning GI physiology from Jim Thompson, who was really one of the leaders in American GI surgery at the time, past president of the college and SSAT, American Surgical.
And was your school funding this?
I got a travel award from the Royal College, but Dr. Thompson had agreed to fund my salary for this research year. But then I wound up getting an extramural grant so that he didn't have to, and it worked out very well.
That's cool.
And that was how many years you were there in Galveston?
From 1980 to 82.
Okay.
And then I came back in 1982 to McGill. And interestingly, about a week after, maybe a month after we moved back to Montreal, a hurricane hit Galveston, and the house or the place that we lived was totally destroyed.
Wow.
So we got out of town just in time. Yeah.
That's terrible.
There are no natural disasters in Montreal, right? It just snows a lot.
We had an ice storm. We once had an ice storm.
An
It was
ice
really
storm.
quite bad.
That's natural. That's a
We
natural
lost
disaster.
power.
I would definitely
Yeah.
call that, yeah.
But you could always shovel snow. When we see some of the natural disasters like in
Yeah.
Florida, we appreciate that it's not so bad.
So are you multilingual then?
I speak English reasonably well, and but I say certain Canadian terms. I apologize for saying a and things like that. But
Don't apologize.
Yeah.
Yeah, this is not, yeah.
I speak fair French. I wish I spoke better. I speak reasonably well in conducting my clinical practice, speaking to my patients, that vocabulary. I don't have the subtleties of the language that I wish I had to understand humor, go to a play and understand really the richness of the language.
Yeah,
But
the
I
subtleties
certainly,
there.
manage well enough in Montreal or in France.
So is medical care all in English then, mostly? Or like,
Well,
you write your
again,
notes in English?
Yes. So the McGill is an English language university in Montreal. There is another French language university called the University of Montreal, that has a medical school as well. And their medical school is, instruction is in French, ours is in English. We recently opened up a French campus outside of Montreal, and the students have the opportunity to write their exams in English or French, even at McGill.
Wow.
Yeah, that's very
But our
unique.
notes are generally, we could write them in either language, but generally most people write their notes in English.
That's very unique. We're going to go and dive into all the surgical stuff because that's what we love. But before we do that, really quickly, so we know what a fantastic person you are in terms of surgical education and mastery, etc. But outside of surgery, what do you like to do outside of the OR, outside of academic medicine, surgery?
A lot of stuff. I love to play tennis. So I play about 4 times a week, I would think. And
Have you dodged injuries, or do you get some of those throughout the years?
I've torn my ACL. I've had 4 operations on my knee.
Wow. Yeah.
Wow.
But I'm still able to do that. I play on hard shoe, on clay, so that it's a little bit more forgiving because you slide. I'm not saying that I'm very good at it, but I love it. And I have a great group of friends, tennis friends that I enjoy spending time with. And then I have a Vespa, as I told you before, my Vespa. So I like to drive around in the Vespa, and I really enjoy good food. Montreal has got some of the best food of anywhere in the world, and the best value, particularly if you're paying with American dollars. So I want to introduce you to some of that when you're in Montreal.
Yeah, we're gonna that's gonna be
right?
Yeah, that's gonna be one of our later questions as we talk a little bit about SAGES Montreal, but we definitely start thinking of some places you want to recommend, because I'm gonna start putting reservations in, and yes, I am buying, Sharon. Yes.
Okay.
Looking forward to it.
Yeah. What else? We love to travel, and I guess that fills up a lot of my time. We love hockey. You can't live in Montreal and not love hockey.
Yeah, that's fantastic. So I do want to hear a little bit more about, I'm sorry about your ACL. I tore my calf last year playing not even tennis, pickleball. So that was an interesting realization that our bodies don't do what we think they should do as we advance. So I was, tennis is definitely one with a lot of movements, a lot of quick things that definitely I think is one of those ones I've heard has definitely high rates of injury. So
you tore your calf at pickleball?
yes, pickleball. That's
For real? I thought you were gonna joke.
No, that it's a dangerous sport. I'm telling you, and it's not even nearly as much as tennis. I mean, we got to throw some color into this. I mean, I literally tore my calf playing pickleball. I
need
was
to warm up. I know Cleveland's cold. You got to warm up before these games.
I
Oh
know.
my God.
So I've been nervous to get back, because I love tennis as well, but I've been nervous to get back to it just because of these injuries. So what, I'm assuming you were out for a while then with that ACL and surgery and everything, right? I mean, you were.
So the worst part of it is that my initial operation, my first operation, was about 2 weeks before we got arthroscopy in our hospital. Yeah, so I had an open meniscectomy.
Oh,
So I tore
yeah.
my ACL and my medial meniscus. And
Okay.
I decided, I was just in practice about a year at that time, and I didn't want to take off the time to go through the ACL operation. So they repaired the meniscus open, and I wore a brace for a while, and then I really wasn't functioning very well. So ultimately I had to have it replaced.
Mm,
And so I did have it replaced. And then I retore the replaced one while I was diving in Great Barrier Reef. And so that I was quite miserable when I should have been having a wonderful time. And came back, I had to be reoperated on. So it's been a series of things, but it's all good now. I'm feeling well, and I'm playing a lot.
I've often tell my patients who've never had surgery that it's tough to make it through life without having surgery. I've had multiple orthopedic myself, and it's just tough. I think whenever you meet an older patient who's not had surgery, like, well, you didn't quite make it. So yeah.
What? Yeah.
Just a way to break the ice a little bit when they're getting really nervous, but
it's nice to share with them, like, oh, then you're going to feel this, and then when the anesthesia kicks in, you'll feel that.
yeah.
What I say about surgery, it's always better to give than to receive.
Yeah, that's right. Yes. So we know that you've played the role of mentor for so many, and you mentioned a few names, but if give you a chance to kind of call out, some of your mentors and their impact on you and making some of the decisions, certainly to go into surgery and then to subspecialize. So yeah, why don't you share a little bit about some of your mentors?
People that really influenced me. I guess the first was my mother's late brother, who was a anesthesiologist in upstate New York, and he was just kind of the epitome of the type of person that I wanted to be, and probably the person that convinced me that I wanted to be a doctor. Just wisdom, character, everything. Despite the fact that he was an anesthesiologist, but he was special. And then in medical school, one of the most I guess transformative moments. I did physiology before I started medical school, and I was at a lecture on respiratory physiology that was given by some guy that I didn't know, and it turned out he was a cardiothoracic surgeon from Hopkins that was doing a PhD in respiratory physiology at McGill, and he had just come back from Vietnam, where he had been a naval surgeon, and his lecture was just fantastic. So after his lecture, I went to speak to him, introduced myself, and asked him if he was looking for a summer student. And I wound up working in the lab with him for the entire time that he was in Montreal. And he was just a terrific person and a great mentor. He went to finish his training at Hopkins and then went on the faculty at Ohio State University. So the person that was his immediate boss in Vietnam in the Navy was Larry Carey. And Larry Carey became chair of surgery at the Ohio State University. Brought Brian Lowry, who was this guy there. And then when I was looking for a place to do endoscopy, I wound up speaking to Brian. He told me that they were missing a GI fellow, and it would be perfect. Chris Ellison was going to do 6 months of GI, and they were looking for someone else. And so Chris and I shared the position in the surgical residency and the GI fellow position. So that was so both Brian Lowry and Larry Carey had a huge impact on me. I mentioned Jim Thompson, and back home at McGill, probably the person that influenced me the most was David Mulder, who was he's also a cardiothoracic surgeon and a trauma surgeon, and he was the chair that hired me. And the thing about him was, if ever I went to him with an idea, even if it seemed crazy, he would let me take the ball and run with it. So, if we have time, I'll tell you the interesting story was one day I was walking through the hospital on a Saturday. I saw a light on in his office, and I knew there was nothing going on in thoracic in the OR. So I went in to see what he was doing, and he was sitting there with a guy that I didn't know. And this guy was a surgeon from Germany, Hans Treudel, and they were writing a book on surgical research. So they invited me to join them for lunch, and Hans Treudel had just done his first operation called laparoscopic cholecystectomy. And he was telling me about this operation, and he said, I'll tell you what, why don't you come to Cologne, stay in my home, and I'm going to teach you how to do this operation, and one day you'll be a famous surgeon. So I went home, told my wife I'm off to Germany, and I went, and I was there for a week. I watched him and his group do 8 lap choles and 1 lap appy. Came back, I went to Dr. Melder and I said, I want to do this. It's going to be huge. He said, okay, make a presentation to the board and see if they'll agree to buy the equipment. So I said, like, maybe you should make the presentation to the board. He said, no, I want you to do it. So I went to the board, told them about this new operation. They said, fine. They bought the equipment. And the amazing thing was, if they wouldn't have acted on it, then it would have taken 6 months to get the equipment, because there wasn't enough inventory to meet the demand as it was taking off. So that's another key influence in my life.
That's a great story.
Yeah, I met him last year at the Central Surgical, he and his wife, and just delightful. And you could see how he would be very supportive of someone coming up. So that's great to hear about it here. I figured his name might come up, but I didn't know your link. Yeah, I met him this year.
So is that how you came to be involved in minimally invasive surgery?
Yes, it is.
Wow.
I mean, I had been doing endoscopy, so I had been, doing kind of image guided surgery. I had actually done laparoscopy a few times without the camera, like early in my practice for diagnosis of abdominal pain and things like that. And I would often do it with a gynecologist because they were using it for, various gynecology reasons. But that's how I got started with laparoscopic surgery.
And I'm always curious, surgeons of your generation that went from open to a completely new technology, did you embrace it because you're interested in technology? Are you someone that is just open to new ideas, or like what made it that for you to do that instead of, I don't know, do some other specialty?
So I could talk about this for long. I always loved technology and I loved innovation. And I had, as I told you, I started with flexible endoscopy. When laser came, I trained in the use of the laser. I was using the laser through the flexible endoscope for ablation of esophageal and rectal tumors, and also for certain types of bleeding lesions. I liked it. When I was in Cleveland for Jeff Ponsky's Festschrift,
Oh my God.
I told a story about how I invented the PEG tube, but true story. And when I submitted the article, he had.
I was also there. I was also at that. That was a great story. Yeah.
Yeah, he had already had his published, and I had developed the PEG tube for use in animals as part of a kind of a research protocol. So no one was really interested in my PEG tube, but it just tells you that I always liked technology and how it can enable us to do what we wanted to do.
It was a PEG tube. It was a PEG pig tube, right? It was a pig.
That's
peg.
right.
It was a pig peg
Yeah.
tube. Yes. They wanted human peg tubes, but not pig pegs tubes.
That's right.
That's great. That's the third Ohio reference in this.
I think it's
already.
even more.
Yeah.
So you ultimately subspecialized in GI, minimally invasive surgery, and I guess this surgeon was correct in that you became famous because you became an international leader in minimally invasive surgery and its education. That's really kind of, I think, where we're going to take the next section. But what inspired you to kind of narrow your clinical focus in this way?
So I always wanted to be a GI surgeon, but it was hard to develop a busy practice in GI surgery because the gastroenterologists were not happy that I was doing endoscopy, and I was a bit frozen out early part of my practice. And that changed after laparoscopy came because they had no one else to refer their cases to, and the patients wanted to have laparoscopy. So it was my goal always to focus on GI surgery. And then and we didn't have colorectal surgeons in our hospital in those days. So I did a lot of colorectal. But then as we built our colorectal group, I went more and more to foregut surgery, which I really, really enjoyed. And at kind of the latter part of my career, I did a lot of foregut surgery and a lot of procedures for the first time, certainly by laparoscopy, which was fun. But I would like to, I would like to call it somebody else in terms of the education part. And it's, you talk about how your life or your career could change abruptly. But I was program director, and one of our residents, her name is Anna DeRosas, came to me and said she would like to do her master's working with me, and she'd like to do it in education. I said, I don't know anything about education. I really didn't. So we sat down and we thought about it, and we were giving courses. So every month we would take 24 surgeons from around the country, and we would teach them laparoscopy. And at the end of the course, we would give them a certificate that they would go home with, and they'd be able to practice, get credentials to practice in their hospital. But it was very clear that there's some people that you would watch, because we were running animal labs in those days, they were just awful. But we didn't have the.
I'm glad you said it. I'm glad you said it. You could just see it. Sometimes you're just like, oh,
that's right. You know it when you see it, but the problem is that how do you decide that you're going to give one person a certificate and someone else not? So I said, Anna, what we have to do is we have to develop a test so that we could test people, see that they have a minimum level of skills. And if we could weed out those people that we thought were really bad and have some criteria to do that, then we're going to be doing a good thing. So Anna really was the person that developed the original part of the FLS box trainer as part of her master's program. And unfortunately, Anna died just a few years ago. It was a very tragic, young woman. And but as much of impact I may have had on her as her program director, she had more impact on me and on my career, certainly than I ever have given her credit for.
So she was a resident then at that time?
She was a resident then, yeah.
That's fascinating. I've seen her name a lot, but it's really unique that that's how it all started.
Yeah.
Because your courses, you're basically validating or associating yourself with the future performance of these surgeons.
Well, I mean, that's what drove us, certainly.
Yeah.
And so the interesting thing was that when I was in Texas, I met Bruce Shermer, former president of SAGES, he was a resident at Duke at the time. And we were at the Southern Surgical and got a chance to get to know each other. And when Lap Coley came, he invited me to Virginia to teach a course, and we were talking, and he said, you have to join SAGES. And I didn't know anything about SAGES. And I said, no, I can't go to another organization. He said, well, why don't you come to our meeting and talk about the education your work you're doing, and give an invited talk. So I talked about the work that Anna had done, and at one of we had an educators lunch as part of the program. And then Bruce introduced me to Nat Soper and Lee Swanstrom and Jeff Peters, and they're talking about this FLS project they wanted to work on. They needed a hands-on part of it, and would I work with them in developing it. And of course I joined SAGES and never looked back. It was the greatest opportunity. So I want to give a call out to Bruce for bringing me into SAGES.
Yeah, Bruce has been mentioned a couple of times. I think he's had an influence on getting people involved in SAGES.
Yeah.
Multiple people that have already mentioned that story. That's really, really fantastic. Yeah,
Go ahead.
Go ahead.
Yeah, you hit one of our questions right on the head, and I think to follow up, simulation is always kind of a moving target in surgical education. I'm actually doing an FLS simulation lab on Tuesday, so this is very timely to speak to you. And despite having some standardized programs, it still remains quite variable, especially when you think of it in a global setting as well. And you may not remember this, but I reached out to you in 2011 as I was planning a trip to Gabon to do the fundamentals of laparoscopic surgery curriculum with the residents the PACS program, which is the Pan African Academy of Christian Surgeons. And you allowed me, and I took the program there, and we started to integrate it into their curriculum, and it's now an ongoing part of their curriculum for the residents there. And I've been back to Gabon and Nigeria a few times, and I always stick to what you put together with FLS. I still have some of the old videos with you, so you know, it's quite great. And but just, you know, telling us a little bit about, you know, FLS kind of, you know, 2.0 and how it, you know, is going to advance and kind of move from what we now do every day to, you know, the next, you know, the global setting as well.
Well, you know, to really understand FLS 2.0, you probably should speak to Melina Vasiliou, who's championing that project. And, you know, when we developed FLS, we didn't have any educational background. Like, none of us did. We knew what the need was. We knew what the content was. We really had trouble finding people with expertise in validation because it was going to be a high stakes exam. We worked a bit with Karen Hoffman at USC at the time, and she really helped us because she had done some work for the national board exam. And but now we have a whole cohort of people that are formally trained in education, and Melina has several of them on the FLS committee. And the revamp of FLS will really be predicated on a deep understanding of educational theory. The validity evidence is going to be, you know, at a level much higher. So I think that, you know, there's lots going on. The whole blueprint, you know, the concept is going to be much more competency based. So it's very exciting, and I think that, you know, it's in good hands. I have to tell you something else though. Like, you know, now my day job is, a lot of it is spent in the simulation center, which I really, really love. But the technology out there with mixed reality, virtual, augmented, and mixed reality, it's unbelievable. And I think that, you know, I just saw an example today of technology where you don't know whether you're in a real world or a virtual world. It blew my mind. And I think that right now that's quite expensive, but we have someone in our lab that could make a digital twin of any person. And I could operate on this hologram of a person while someone else with a headset can follow along on the real person. And, you know, the ability to teach using technology, it's just accelerating at a pace that, you know, it's staggering. So right now we're working on 2.0, but really in a year or two, the technology will be so advanced that we'll be able to remotely train people, you know, who can afford a headset at the price point of an iPad or a laptop, and anywhere in the world. And you don't have to go to Gabon or Nigeria. You'll be able to, you know, to ship them or loan them, or they could buy a few headsets, and you can instruct them on a simulator or on even a real patient. You'll be able to support them. So it is so exciting. It is so much fun.
That
and
is so exciting.
Yeah.
As much as I like that, you know, 25+ hour journey across the continent and back over, it'd be great to just sit here and do it too.
Yeah, and how many times can you go to Gabon?
Yeah, I mean, it takes,
you could do it.
Yeah, it takes a while to get there.
Well, Kevin's pretty dedicated. You go every year, right? At least once a year.
Yeah, I usually go once a year. Yeah, once a year.
Well, it's because, you know, you don't mind leaving Cleveland.
That's true. I always go in the winter. That's right.
Oh, Gerry's on my side now.
Yeah, that's true. I always go in like November, December, January. I get the heck out of here.
Yeah. I could feel free.
There's also video-based assessment, right? So you're, besides the hands-on, can you maybe give us a little bit about what's going on with video-based assessment in surgical skills education?
So, you know, the idea is that one of the opportunities that image-guided surgery provides us is that we have a camera, whether it's a flexible endoscope, whether we have a rigid endoscope, whether we have a robotic imaging system. We have an ability to capture what we do, and we have not really maximized our opportunities both for teaching or evaluation of what goes on in the operating room. And you know, and I don't have to tell any surgeon that what we do in the operating room really matters. you construct an anastomosis poorly, it's more likely to leak. If you don't fix a hernia properly, it's more likely to recur. I mean, what
Yes.
we do matters, and we don't capture what we do at all. We have an operative report, which is, I guess it's an optimistic view of the way the operation went in the eyes of the surgeons, but it is not a very useful
Often a template now, you know, it's
Yeah.
it's not even, it's just a template now. Yeah. So
it's really not very useful to harness rich information and be able to use that information as a way of assessing quality and to use it for teaching. But now I think with the ability to record operations routinely, and with the type of processing power that computers have and the algorithms that artificial intelligence and computer vision offer, this opaque part of care that's in the operating room, I think, will become much more transparent, and it will be a way that we assess our trainees and ourselves, because I think it's our responsibility to the public to make sure that people that do surgery are skilled, remain skilled throughout their career, and continue to aspire to improve their performance like any elite performer would.
Yeah.
We wouldn't have a professional musician or an athlete that would, the day they get their first contract, stop training or aspire to continue to improve. But we've been a little remiss in surgery, and I think the idea of video-based assessment in a formative way, not in a
Punitive,
in
yeah.
a punitive way, but it will be a powerful tool in improving what we're able to do and learning from one another.
Yeah, and that makes so much sense. And I was, it was a great session last year at SAGES with the video-based assessment session that you co-chaired, and I know that a lot of research is being done that, we're enrolling in a validated surgical skills education program with video-based assessment can actually translate to better patient outcomes. And I assume this was one of the key aspects of integrating so much of what you've built into the American Board of Surgery Qualifications. Is, how did that kind of relationship develop?
Well, you're probably asking like the wrong person, right? I'm a Canadian, and
I know, but
the American board is,
yeah, that's
Yeah.
true. That's true. But but a lot of the
Yeah.
programs were integrated. I mean, that's what we do now. I mean,
So, if you want to learn something from how simulation became impactful in aviation, it was legislating that simulation was mandatory for all pilots, right? And that made the simulation industry thrive, and it reduced the number of crashes and things like that in aviation. Well, our goal, once we developed FLS and had data that's supported its validity, was to mandate it. And that was really, I would say that it's probably Lee Swanstrom strong, he felt the most strongly about it. I was a little reluctant, but he felt very strongly that the FLS should be a mandated thing. And we went to the board, and it was iterative. The first time we went to the board, essentially they didn't show great enthusiasm. And I remember trying to get the American College on side, and Jeff Peters and I presented to the Board of Regents, and we really were I wouldn't say poorly treated. We were not warmly received.
Very diplomatic. That's a very
the,
Canadian way of saying that you were poorly treated. I love that.
No, I mean, the people in that room were not all that enthusiastic about people assessing them by this test. But ultimately, we kept getting data, and we went back to the Board of Regents, and they, to their credit, decided to support us. And I think having the college on side was a very powerful ally. And then we went back to the American board, and I believe that Jeff Ponsky was actually the president at that time. Or
Yeah,
I can't remember
that's
what the
right.
title was.
Yeah,
They
he
had
was
a
on the
retreat
seat,
in Sarasota in the wintertime, and reluctantly I went. And
I'm sure that was
stayed
a
at the Ritz
tough
and
visit. Yeah, that
presented
was a
the
tough
data, and ultimately they decided to come in to mandate FLS at the same time as ATLS, and I think that was a huge and brave move by the board. So when flexible endoscopy became an important area where we wanted to demonstrate that surgeons should get privilege, not just because we say so, but because they showed that the quality of the work, the quality of their endoscopy was at a standard that, that is respectable. We worked on developing the FES model that was led by Jeff Marks and Brian Duncan, with endoscopists, so that would agree on the same standards. And when that program was validated, then we went back to the board and were able to get their support for FES. I think that is huge, and I think it's a brave and bold step that the board took. But if the board's responsibility is to protect the public and ensure that the people that take care of them are appropriately trained, then we have to show not only that we know things, but we actually can do things that we say we can do.
And what about
Well
the
said.
Canadian Board of Surgery? How?
So it's part of each program, so it's not mandated within at the national level, but each program is part of the accreditation of the individual programs that the residents take FLS.
Oh, got it. And then I just want to know like how you got into SAGES. Shermer did kind of got you involved, and then you eventually became president.
Yeah.
So maybe you can kind of tell us. We're always encouraging our listeners who are SAGES members to get involved. Actually, my first involvement in SAGES was at the FLS committee. I worked at USC as my first job with Jeff Peters, who was there, and Lee Sillen, and they got me involved with the FLS committee. That was my first foray into SAGES.
Fun fact. That's a fun fact.
Yeah. So how did you kind of go through the process and eventually become president?
Okay, so before I tell you that, I just need to tell you that Jeff Peters, former president, was my intern when I was at Ohio State that year.
What?
Wow.
Yes.
Was he a well-behaved intern?
Yeah,
or
was he
I would never say anything other than he was a perfect gentleman. We got reconnected.
even as an intern?
He did everything we asked of him.
Yeah, that's great.
and more.
Yeah, he and Carl Zucker. I don't know if you remember Carl Zucker. He wrote one of the original books on laparoscopy. They were my two interns, and they were really two of the early heroes in that world. Anyways, I became a member of SAGES after that meeting, and immediately got involved in the FLS project. And then, as the FLS committee was starting, I was basically one of the co-chairs. And went on to become chair of the FLS committee, and just got involved. I mean, we would have a ton of papers from McGill on at the SAGES meeting. I had some really good residents. You may have heard of Leanne Feldman and Melina Vasiliou.
Yes, of course.
Simon Bergman, and we had just a whole group of great people in the lab, and we went from like nothing to having like 10 papers on every year. Alan Okranik, also came through, and we, just got involved in the program, and people said it was a meritocracy. It truly is. I didn't know any people really well before I started, but I was really warmly received, and I never felt that, as a Canadian, that my opportunities were lessened.
Yeah, that's great.
Yeah, I would agree with that. Leanne was one of our earlier guests, having been just a recent past president of the SAGES Society, and we hope to have more Canadians and less Ohioans in the future.
Yes, definitely has got to balance out for sure. So you were president just about a decade, little less than a decade ago. What were your goals for the society at that time? And then how have you seen SAGES evolve since then?
So around that time, I was chair of surgery, and we had a chair of anesthesia, a man by the name of Franco Carli, who we became good friends. And Franco and I started a fellowship in minimally invasive anesthesia. We co-funded it. And we started to look at how we could make the trajectory of care for our patients that we were operating on as quick as possible, as easy as possible. And so we wouldn't want to hit them with the same hammer for an MIS procedure as we would for an open procedure. And so how could we modify this? And he introduced us to Henrik Kellet, who was a Danish surgeon who really developed the concept of what was called at that time fast track surgery. Leanne got very interested in surgical recovery and how to measure recovery. So one of the things that I wanted to do when I was president of SAGES was to look at the concept of enhanced recovery after surgery. And, how do we make sure that, look, we're doing a lot in the operating room to mitigate the injury of surgery, but all the other things with opioids, with fasting, with tubes, drains, etc. We still hadn't learned which we should do, what we shouldn't do, how quickly we could ambulate people, how quickly we could feed people after GI surgery. So I really wanted SAGES to get involved in that area, and Leanne was really the person that was going to be the point person on that project. And I think it's really evolved, and it's, I think everyone in the world now is talking about enhanced recovery after surgery in some form. It's just, part of the way we care for surgery. So that, that was really my main goal and my time as president, to help Leanne and her group, really, who took ownership of this program, bring that into SAGES, and through SAGES to influence the way we care for patients.
Yeah, that's ERAS, Enhanced Recovery After Surgery, which, we have it for all different operations, right? We have it for colorectal, we have one for hernia surgery. Yeah.
It's really
was SAGES involved in guidelines before you became president as well, or did you kind of spearhead all the guidelines?
No, guidelines actually preceded me.
Okay.
So I can't take any credit for that.
You don't take credit for anything. You're too humble.
Yes, this is true.
It's like I'm the wrong person, except I was involved with all these things.
Aww.
We got to hear you say a couple things that come on, Gerry, you're a stud.
He is.
I don't mind you saying it, Kevin, or I don't have to say it.
Yeah, that's okay.
Very sweet and Canadian of you.
Yeah, that's it. Yeah.
All right. Well, I do want you to, give us some stuff that you will kind of take ownership of, and that is in our next section of our SAGES Story podcast, which we call "We Are the Surgeons."
We are the SAGES. Sing it, everybody. Have you had a good time tonight? There's a choice we make. We got a lot more coming. We are dancing, singing. It's true. Let's give a big hand for SAGES Party. Give them a big hand.
Yeah.
So each guest is asked to share their most memorable or salacious memory of the annual SAGES stories. Of the annual SAGES meeting. What's your story from the meeting?
So I would not say anything salacious, because it's just not in my personality, of course.
You would be the first, but okay.
No, I guess, like most people, the thing that hits you most when you go to your first SAGES meeting is the sing-off. And having been at surgical meetings that were somewhat more formal, the big social event would be a black tie dinner and a 30-piece orchestra, and no one would be dancing. Like, that would be like the social event where there would be a speaker or something. To go to SAGES and to just see honestly the humility of the people in leadership. And when I first started in the organization, like everybody else, the people in leadership were big names in surgery, and immediately, they were brought down to earth, and they were accepting of people, and the ability to just get to know people in a level, at a level of informality that SAGES provides. That was the culture that I think is so rich. And I hope that as there's a lot of talk now, what's the future of these meetings, and the friendships and relationships you develop through these organizations they're one of the greatest parts of my career. And I look back, the friendships. And, when we didn't see everybody for the couple of years of COVID, it made you appreciate what you got when we were able to get all together again. And some of my closest friends in the world are people that I met through SAGES. The warmth and sincerity of them. It's different when I'm with the same people at different organizations. People just act different. And I hope that SAGES will maintain this informality and the approachability of people and the opportunity for young people to bring a good idea and to take the ball and run with it, so to speak, because that's what makes this organization special. So I don't mean salacious, but I just think that you are now the guardians of the organization, and I think that it's really important that the culture of the organization matches the membership and is attractive to the membership and makes people want to come to the meeting. And I would encourage people to bring their families. I mean, Karen has come to almost every SAGES meeting, for 25 years. Maybe she's missed like 2 or 3 during that period of time. And she knows every one of my friends. She knows many of their spouses. She knows many of their kids. We've had them to our home. It's just a special relationship. She understands my day job as a result. So I think that, it's really, really important that we make people want to come to the meetings and feel that there's something about a SAGES meeting that will always be different from other organizations, which are wonderful. I mean, I belong to a lot of them, but SAGES is very special in my heart.
Yeah, I think we all share exactly what you said. It's also very unique to have major surgeons in our field, such as yourself, just mingling amongst us normal people, little people. I feel like you've mentored, taught, promoted so many young surgeons. I feel like that's been one of your strengths, is your ability to kind of reach out and influence each newer generation. So based on what you said, what's your message to the younger surgeons about A, their involvement in SAGES, and B, the future of surgery as a whole?
So, to the young surgeons that really follow your passion, find something in your practice that you really that you really love, that you're really passionate about, and SAGES is the organization to take that to. Also look ahead rather than back. Look at the way that the surgical practice is evolving, but also look at technology, understand what's going on in engineering, and ask yourself, how can we take what's going on in some of these other fields and make what we do in surgery even better, safer, less painful, quicker recovery. Think through the patient's eyes. I think there's an opportunity to do that as a young surgeon, because you're kind of close to it, and I think you're very open to technology and innovation. But bring it to an organization, because you can't do it on your own. The other thing that's evolved over the time that I've been at SAGES is that SAGES used to be an outlaw organization to some extent, but over time, a lot of the SAGES leadership have become leaders in American surgery in every sense, right? Whether it's Joe Beisky at the board, whether it's my role as chair of the board of the regents of the college, in American Surgical, like in all these organizations, SAGES people have gone into leadership roles. So the people in the room are now leaders of American surgery, and having access to them in an environment like SAGES provides the young people an opportunity to get involved in really exciting and important projects.
I have a question for you. I've been wanting to ask you for a long time. So it seems to me we're doing a really good job with FLS and even robotic education as a kind of a next generation of that. Do you feel like we're going to have to eventually have some type of validation for open surgical skills?
I don't think we're going to need necessarily to have a validation, but we may need to rethink the way we educate people and the way we evaluate all our trainees and ourselves. it may have to evolve. We will always be doing open surgery, or for the foreseeable future, certainly, and we can't ignore that. But I haven't found our residents struggling doing open surgery, because they do a lot of things like compatibility stuff, transplant stuff, big trauma procedures. So they're pretty comfortable in the abdomen. They won't know the nuances of doing an ulcer operation. Like, I did 150 ulcer operations my first year in practice, believe it or not. It was very prevalent then. They don't know how to do a difficult duodenal stump, perhaps, or they may not know how to get exposure for every area of the abdomen, but they're not struggling taking out a gallbladder open if they could do pancreatectomy or a liver resection or a transplant. They're pretty comfortable in the abdomen. So, I think our residents in general are very well trained still. They're very talented people, and their open surgery skills are not worrisome. But we have to still be careful to ensure that they get proper training in everything that they're going to do when they go out there.
I think that's a fantastic question, and certainly you're dealing with la crème de la crème at McGill of residents, but I think there is definitely going to be some concern when you have programs where maybe your access to those big operations are less, and especially as the body habitus change, and there are a lot of nuances that I think are going to become an issue, and I think some are concerned about the training in open surgery. I've actually started to record even open operations for that very reason, just to have the technical aspects readily available to go through, because we don't do it as much. So
that's right.
Well, you have been a very gracious host, as we expected, and most of all, as always, you've been inspiring and have provided a fresh take on everything we do as surgeons. Next year's SAGES annual meeting, we've been alluding to it, is from March 29th through April 1st in your hometown, Montreal, Quebec. This must be very exciting for you. I hope all of our SAGES members who are listening plan to attend. And then, of course, we want to know any tips on what we will be expecting to do in Montreal in March.
Or what we should be wearing, because I'm from a place where there's very little warm clothing.
They don't own parkas or snowshoes in Los Angeles.
Definitely no snowshoes.
Hopefully you won't need snowshoes, but you will need you will need to layer up a little bit. Yesterday it was almost 80 degrees in Montreal, which is like crazy for the end of October. Maybe we'll be lucky and we'll have a hot spell while you're there. But I want to tell you, Montreal is the second largest French-speaking city in the world. And it is a little bit like being in Paris, but in North America.
Love it.
People will not have trouble navigating if they don't speak French, but you will be able to really enjoy the French culture. As I said, the food is fantastic. There's lots of things to do, and there's a whole underground city that radiates from the headquarters hotel, from the Fairmont Hotel, so that you can walk literally miles and go to places, without coming
up for air,
up to the surface. Something
I've
special
heard about that. Yeah.
Try to go to a hockey game. Watching the Montreal Canadiens play at the Bell Center where they play is like going to Yankee Stadium to watch a baseball game, or Fenway, or it's one of the iconic sports venues in the world. There will be spring skiing for those people that want to ski.
How far to ski? Ski?
Well, the closest would be about 45 minutes.
Okay.
Yeah. It's also sugaring off season. So Quebec, the province of Montreal sits in, is the largest producer of maple syrup in the world. And sugaring off is the time of year in the spring where the sap runs. And they have these cabins that you could go to where you could make maple syrup and have a traditional sugar shack meal, probably as unhealthy as anything you could possibly
Yeah,
describe.
that
But it's an
sounds
amazing, it's an amazing
diabetogenic.
experience. Exactly.
Diabetes, 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 diabetes.
So that's a fun thing. Montreal also, you can get out of the city to beautiful lakes and forests and all that within an hour. So there's lots to do, and I welcome anybody to contact me if they want some ideas or something
I
special.
cannot wait.
Yeah, what about some restaurant names that you want to drop while we have you too?
Oh, I don't know. I mean, am I allowed to do this? But there are some
Yeah,
incredible.
sure.
So
Yes.
Absolutely.
there's a restaurant
They're going to
called,
sponsor the next Sages Story.
Yeah, exactly.
podcast.
They're gonna be like, oh, we got 18 reservations just today. Yeah.
so there's a wonderful restaurant called Le Filet, Filet, means like the net. Actually, it's across from a tennis facility.
Okay.
It's kind of a seafood Asian fusion type restaurant. It's amazing. There's Milos, which is one of the best fish restaurants in the world, and they started in Montreal. They have branches now in New York, Las Vegas, Athens. It is fantastic. There's some obviously wonderful steak restaurants. So I'm trying to figure out where to take the past presidents for dinners. We'll have somewhere really special.
Oh,
There's a great place called Europea. It's a Relais Chateau restaurant that's it's a real show. I mean, every course is like a work of art. There are many others. There's some, I mean, literally one of the best Syrian restaurants I've ever eaten at, called Damas, Damas.
I was there actually. I was in Montreal last a couple months ago, and I went to that. So
Yeah,
you're right.
did you like it?
It's amazing. Oh yeah, it was fantastic.
Yeah,
Wow.
we took Sally. Sally Matthews was in Montreal as part of the planning, and we went there for dinner with her. It was great.
Yeah, that was amazing.
so looking forward to it. So looking forward to it. Gerry, I really appreciate your time. We both appreciate it. For our listeners, if you want to learn from the best and meet Dr. Gerry Fried, please attend the annual SAGES meeting. That's this March 29th to April 1st. And make sure you say hi or bonjour to Gerry when you see him there.
Please do.
And make sure Kevin takes you out to Europe.
Damas.
Or
No,
Damas.
Europea or
Damas.
Dama.
I just want to thank the two of you for doing this. I think it's really fantastic. It's really fun. I hope people enjoy it. But I think having a chance to get to know the people within our organization, is such wonderful people. It's a gift. So
It's a
truly
gift.
appreciate it. Thank you.
It's been a gift. We agree. Thank you so much, Gerry.
Thank you so much,
Okay.
Gerry.
And that wraps up today's episode of Sages Stories. You can view the show notes for any links to sites we referenced today. Visit sages.org for membership information and for the most recent news from our society. Follow us on Twitter at @sages_updates. Make sure you hit the like button and subscribe so you don't miss any future episodes. See you again next time, and remember, you can't spell minimally invasive surgery without SAGES.